Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 35. We're going to be talking about viral hepatitis. There are 5 different hepatitis viruses. They each come from a different virus family. They have different genomes, they have different replication strategies, but they all cause hepatitis or inflammation of the liver. We'll go through each of the subtypes and help you distinguish them from one another. You need to be familiar with the serology and the serologic testing for the different phases of the disease, but we'll go through that together. Welcome to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 35, Hepatitis Viruses. There is a family of hepatitis viruses, or a family of viruses, which cause hepatitis. This slide shows the interesting fact that each hepatitis virus comes from a different virus family. Hepatitis A is a picornavirus, Hepatitis B is a hepadinavirus, Hepatitis C is the flavivirus, Hepatitis D is just an RNA virus, and Hepatitis E is a calicium-like virus. So there are 5 RNA viruses, and there's 1 DNA virus, which is Hep B, but it thinks it's RNA. Hepatitis A virus causes acute infectious hepatitis. It's caused by a picornavirus, which is a small, non-enveloped, icosahedral particle of single-stranded positive-sense RNA. The vaccine is a dead virus. Hevirix is the name of the vaccine. Transmission is excreted in the stool, and it's passed by the fecal-oral route. So if you eat contaminated food or water, or have infected food handlers, you're going to get it. You can also get it from shellfish in infected waters. Hepatitis A enters via the gut, replicates in the gut, spreads to infect the liver. Then once it's in the liver, it multiplies in the hepatocytes, where it causes hepatocellular damage and an increase in the transaminases. That gives you jaundice. Clinical findings include a 2 to 4 week incubation period, where you are asymptomatic but shedding the virus for other people to enjoy. Then you get the symptomatic, which is the acute, sudden onset of fever, anorexia, nausea, vomiting, jaundice. It resolves spontaneously in 2 to 4 weeks, and you get fulminant hepatitis only rarely, about 0.1% of the time. Lab diagnosis: it cannot be cultured in vitro, and so you look for the presence of hepatitis A virus-specific IgM. That indicates acute infection. If you find IgG, that indicates immunity due to either infection, which is old, or vaccine. This is a figure showing the antibody and antigen spikes in serum that go along with time. As you see, by the time you get to 15 to 45 days, you have fecal hepatitis A virus that spikes in the blood, and it goes down rapidly as soon as you get IgM against hepatitis A virus. Slow after the hepatitis A IgM comes up the IgG, which is longer lasting but slower to get started. You can see that your acute disease happens when you have less of the hepatitis A antigen and you're getting the antibodies coming up. You have convalescence and recovery long after you've cleared the virus, and you have protecting antibodies to keep you from getting sick. Treatment and prevention includes hyperimmune serum for post-exposure prophylaxis, or you can do inactivated cell culture-derived vaccine, which is recommended for people who are at risk. Healthcare workers, childcare workers, sexually active gay men, and travelers to endemic areas. People who have established infection, we just treat them supportively. Question: which of the following statements regarding hepatitis A infections and hepatitis B infections is false? A. Acute hepatitis A infection is clinically indistinguishable from hepatitis B infection. That's true. B. Hepatitis A infections are generally benign, self-limited diseases. That's true. Although it's no fun to have it, it usually stays all by itself in the liver and goes away. C. Fulminant hepatitis may occasionally occur with hepatitis A. That's true, about 0.1% of the time. And D. Hepatitis A can progress to chronic infection in a carrier state. That's not true. That's more consistent with hepatitis B. Speaking of hepatitis B, it can form acute and chronic infections of hepatitis. It's from the hepadinavirus family. It's an icosahedral nuclear capsid with an envelope containing surface antigen. It has circular, partially double-stranded DNA genome. It has its own DNA polymerase with its own reverse transcriptase ability, and humans are the only known hosts. Hepatitis B genome has 4 genes: polymerase, envelope, precore, and X. Pol, as you might imagine, encodes the viral DNA polymerase. Envelope encodes the envelope glycoprotein, which is a hepatitis B surface antigen. Precore encodes the precore protein, which is processed to the viral capsid to be hepatitis B core antigen. Alternative processing of precore gives also the hepatitis B E antigen. X encodes protein X. The function of protein X we don't know about, but it may be involved in the activation of host cell genes in the development of cancer. This figure depicts the life cycle of hepatitis B. You get, in the top left, entry into the cell, and you get exposure of the nucleocapsid into the cytoplasm. The core particle then translocates to the DNA, into the nucleus, where its DNA is replicated and repaired. After transcription of the herpes DNA, the mRNA proteins go out into the cytoplasm where protein synthesis takes place. Then you get core assembling and RNA packaging, and you get everything ready, and then you bud into the endoplasmic reticulum. Then a vesicle takes the transport to the cell membrane where it's released to go and infect other cells. Hepatitis B replication involves a reverse transcriptase step. The virions bind to the cell surface receptors and enter. The core is transported to the nucleus. The DNA is completed into a circular strand, and then mRNA for proteins larger than the genomic mRNA are generated. Nucleocapsids are assembled in the cytosol with genomic RNA in the core. Reverse transcription of RNA happens in the capsid. The negative stranded DNA is synthesized, degrading the RNA. Then you have a positive stranded DNA synthesized, but you run out of substrate, so it's a partially double-stranded DNA. Then you bud into the endoplasmic reticulum to be enveloped and exported. Transmission of hepatitis B virus happens in the exchange of contaminated blood. Blood transfusions used to not be screened for hepatitis B. Organ transplantations are a common cause, and contaminated needles. Sexual intercourse is also another way to change hepatitis B, and vertical transmission from mother to child during delivery. There is a vaccine available which contains hepatitis B, IPV, and DTaP. Pathogenesis. Hepatitis B leads to viremia, which spreads to infect the liver. Once it gets to the liver, it multiplies in hepatocytes and integrates into the host genome. Then you get hepatocellular necrosis and inflammation. The risk of primary hepatocellular carcinoma persists after chronic infection. So you get liver cell injury that's a result of immune response to viral antigens expressed on the infected hepatocytes. Clinical findings include an incubation of 4 to 20 weeks, usually 2 months. 90% of cases are acute, 10% are chronic. You can have an asymptomatic acute phase in 2/3 of people, and a symptomatic acute phase in 1/3, where people will get fever, anorexia, nausea, vomiting, jaundice, and increased LFTs. 8% of people can develop a fulminant hepatitis, which is fatal without transplantation. You can also get chronic persistent hepatitis B with minimal chronic hepatitis, and asymptomatic carriers are 80% of perinatal infections. The moms don't know they have hepatitis B because they're asymptomatic, and yet they're chronic carriers. Chronic active hepatitis B is severe chronic hepatitis. That'll lead you rapidly to cirrhosis and primary hepatocellular carcinoma. This figure identifies the antigen and antibody sequences in hepatitis B. Basically, as you go from months after exposure, the first thing that shows up is the HB surface antigen and the HBe antigen. When those things are high, you have a prodromal or acute phase. Then you enter a window period where you don't have any anti-HB surface antigen, and you don't have any anti-surface antigen, you don't have any anti-surface antibodies either. The only thing present at that point in time is anti-HB core. After that, the antibody levels peak, the antigen levels diminish, and you have chronic infection. Acute hepatitis B. You can do assays for hepatitis B surface antigen, and you use that to detect early hepatitis B. It appears in the incubation period, and it's detectable during the prodrome and acute phase. The presence of the antigen means you have live virus, whether you're acute, chronic, or a carrier state. If you've got antigen, there's virus in there making it. Hepatitis B E antigen indicates high infectivity and active replication. If you have anti-HBe antigen, that suggests low infectivity. Anti-core is not protective, but it is the first antibody to appear, and it's seen in the window period. Acute illness shows IgM and chronic or resolving people will have IgG to anti-core. Hepatitis B surface antibody develops when the surface antigen disappears, and the patient is protected and immune. The window period is when you have no surface antigen and no surface antibody. There is a zone of equivalence between the antigen and antibody, and their appearance of surface antibody a few weeks to months later means that there's a disappearance of the antigen. The serum becomes negative for the antigen as it's precipitated out by the developing antibodies. Lab diagnosis for chronic hepatitis B infection is shown in this figure. After a few months, you no longer have surface antigen around, and what it shows is the anti-core antigen shows up first. This figure depicts hepatitis B chronic infection. The key distinguishing characteristic of this graph is that there is no anti-surface antibody. Okay? So this big purple bar all the way across shows the presence of the presence of surface antigen, which means there's live virus. Also, for the first few months and or years, you have hepatitis B E antigen without any antibody. That indicates active replication and high infectivity. Even though you have anti-core antibodies, the presence of these two antigens is bad news. Eventually, the E antigen gets replaced by the anti-E antibody, but you always have surface antigen, meaning you don't have any surface antibody, and that's a sign of chronic infection. This slide shows a table which summarizes the lab diagnosis for the different stages of hepatitis B. In the acute disease, you're surface antigen positive. You have IgM against hepatitis B core, but you don't have any surface antibodies available. Once that's resolved, you no longer have the surface antigen, you do have surface antibodies, and your anti-core antibodies are now IgG. When you have chronic infection, you don't have surface antibodies, but you do have surface antigen, and you have anti-core antibodies. When you're vaccinated, the only antibodies you have are to surface. You don't have any anti-core antibodies, and you don't have any surface antigen available. So if you're chronically infected, you can be high titer virus or you can be low titer virus, depending on whether or not you have E antigen available. Like we said in the previous figure, if you have E antigen, there's active replication, you're very infective. But if you have neutralized that and you have E antibodies, then you don't have any antigen available, you have low titer virus, and you're not very infected. This table shows another summary of the hepatitis serology markers, as we just talked about. It's important to know each of the different phases, and you'll be tested on this. Here we have another table which shows us the anti-hepatitis antigens. You can see that this is something that frequently shows up on step 1, and this is a reiteration of what we talked about before. Let's go to some questions. A 25-year-old male recently suffered from jaundice. He's got a lab workup that's positive for hepatitis B surface antigen, positive for hepatitis B core antibody, and negative for hepatitis B surface antibody. His clinical status is, this is like we talked about with the second figure. You've got antigen for surface, antibody against core, and no antibody against surface. So you have chronic hepatitis B, which is choice C. Next question. During a physical exam and lab workup before starting a new job, Thomas is found to have antibody against hepatitis B surface antigen. His serum is negative for all other hepatitis markers. His lab finding is indicative of, when you vaccinate people against hepatitis B, you expose them to surface antigen in small amounts. That allows them to make antibodies against surface antigen. So you don't ever see the surface antigen again, but you do see the antibodies against it. Since you've not been exposed to any other hepatitis antigens, you won't have any other serology. And so this is an example of vaccine-induced immunity against hepatitis B. Thomas should be fine in his new job. Next question. A medical student, while drawing blood from a patient, accidentally sticks herself with a needle. 3 months later, she develops symptoms consistent with hepatitis. Serologic testing for hepatitis B surface antigen, hepatitis B surface antibody, and hepatitis A virus are all negative. Serology is positive for the IgM core antibody. The medical student has which of the following? So we know that she doesn't have hepatitis A because that's the only antibody we deal with when we have that. We can't say that she has hepatitis C because we don't have any information on that testing. But we can say that he has hepatitis B because they have positive antibody for the IgM core. That means they've been exposed to hepatitis B, but they're in the window phase to hepatitis B because they don't have any surface antigen, they don't have any surface antibody. The only thing that's positive is the IgM core antibody. So C is the correct answer. Next question. The presence of hepatitis B surface antigen and the presence of E antigen is well indicative of which of the following? We talked about this before. If you've got surface antigen and E antigen, you've got active replicating hepatitis, and that's A, infective and active hepatitis. The other answers don't apply. Next question. A lab test that will distinguish a recent exposure to hepatitis B virus from long past exposure to the virus involves detection of which of the following antibodies? So detecting recent from long past includes the change between IgM and IgG. If you have core antibody, that means that you've been exposed. And if you have recent core antibody, like IgM, that tells you that you've been recently exposed. If you have IgG, you don't know whether it's recent or whether it's long-term, because that can show up in both. Next question. A 26-year-old male patient comes to the physician's office with jaundice, loss of appetite, clay-colored stools, and generalized feelings of being unwell. Liver function tests show elevated transaminases, and the serology for hepatitis is positive for Hep B surface antigen. It's negative for Hep B surface antibody, and it's positive for hepatitis B core IgM, and positive for hepatitis B E antigen. The most likely diagnosis is, so this is another variation of the same thing. We have hepatitis B surface antigen, we have hepatitis B E antigen, and so we have active infectious hepatitis B. So the answer is A, acute hepatitis B infection. Treatment and prevention against hepatitis B includes alpha interferon. You can also try lamivudine, which affects the reverse transcriptase, or you can prevent it through a vaccine or through hyperimmune globulin. Infants of Hep B surface antigen positive mothers have a risk of the carrier state and hepatocellular carcinoma. They are universally vaccinated, and the infants get immune globulin in 3 doses of vaccine. That offers 95% protection. Moving on to hepatitis C virus. This is a single-stranded positive RNA genome. It's enveloped, and it's a member of the flavivirus family. It replicates in hepatocytes and mononuclear cells. It has poor fidelity of the HCV RNA polymerase, and so it's unsustainable. There are several mutant strains that can be detected within one individual, and elevated IgE does not confer effective immunity because of the polymerase is unstable. Transmission happens by a number of ways: blood products, IV drug abuse, vertical from the mother to the infant, sexually, and it's frequently found in hospital workers. Clinical findings include an incubation period of 2 to 26 weeks. Acute hepatitis is less common, and it's milder than hepatitis B. You worry about with hepatitis C the complications of chronic hepatitis and cirrhosis, and also the likelihood of hepatocellular carcinoma. Persistent infection, chronic hepatitis are the hallmarks of HCV infections. Lab diagnosis for hepatitis C includes an HCV-specific IgG. That means you've been exposed. RT-PCR can detect the viral genome in serum. You've got hepatitis C RNA testing must be performed to assess viral replication and confirm HCV infection. In symptomatic acute HCV infection, antibodies are detected only in 50 to 70% of patients. Question. A 35-year-old IV drug abuser presents with elevated liver enzymes, jaundice, and wasting. Workup for Hep A and Hep B is negative. The clinician suspects Hep C. Which of the following lab tests will confirm the clinician's diagnosis? So IgG antibody will show that they've been exposed, but it doesn't necessarily mean that they're active in hepatitis C. IgM antibody will also show recent exposure. Hepatitis C virus RNA testing by molecular methods will show not only that they have been exposed, but also that they have active replicating hepatitis C. So C is the answer. Hepatitis D virus is also called the delta agent. It has a small RNA genome. It has an envelope composed of hepatitis B surface antigen. which is unique. You'd think it'd have its own surface antigen. It has a circular, single-stranded negative genome. It's replication defective, and so it requires hepatitis B as a helper virus for replication. So you can have acute co-infection, where you have both new viruses infect the same cell, or you can have superinfection of an HBV carrier. It's common in drug addicts and hemophiliacs in the U.S., and the lab diagnosis includes HDV RNA, or an IgM against both HD, AG, and HB core antigen. Question. A 21-year-old drug addict was infected with hepatitis B and hepatitis D virus together as a result of needle sharing. This is known as co-infection. Superinfection is when you have pre-existing hepatitis B and then have hepatitis D on top of that. Recombinant infection is not a term we use with these viruses. Next question. A 21-year-old hepatitis B carrier becomes infected with hepatitis D virus. This is known as superinfection, as discussed above. Hepatitis E virus is non-A and non-P hepatitis. It's spherical, non-enveloped, linear, single-stranded positive RNA, and it's found in the calicivirus family. It's passed by fecal-oral transmission, and you have epidemics in India, Africa, and Mexico. Its infection is self-limiting and found in young adults. It may also cause fulminant hepatitis in pregnant women. It has a high mortality rate, like 20% in this population. The lab diagnosis is based on hepatitis E virus RNA in stool and in the liver and IgM. Question. A 35-year-old waitress presents with malaise, loss of appetite, fever, jaundice. The lab tests indicate elevated serum transaminases. Her workup for hepatitis indicates positive results for the presence of hepatitis B surface antigen and hepatitis B core antibody, IgM. Her hepatitis C viral antibody is also positive. Which of the following is the most likely diagnosis? So you have somebody who has positive results for hepatitis B surface antigen. So we know they've been exposed to hepatitis B, they have it. They also have hepatitis B core antibody, and so they're mounting a new immune response to it. But they also have hepatitis C antibody. So this is somebody who, by definition, has active hepatitis B. But just because they have antibodies against hepatitis C doesn't mean they have an active hepatitis C infection. And so what we have is acute hepatitis B viral infection. Next question. A 47-year-old male patient presents with jaundice, right upper quadrant pain, along with anorexia and loss of appetite. Physical exam reveals a nodular enlarged liver. CT scan shows cirrhosis with a large mass. Infection with which of the following viruses would be most likely related to the development of this mass? So we're talking about hepatocellular carcinoma. The big ones you worry about with that are hepatitis B and hepatitis C. And since we have hepatitis B as an option, it's going to be that. Epstein-Barr can form Burkitt's lymphoma or other lymphomas, but that's not usually going to be lodged in the liver. HHV8 can cause Kaposi sarcoma, but that doesn't happen in the liver. And HPV can cause cervical cancer, but not in the liver. Next question. Which of the following viruses has part of the genomic DNA synthesized by a virion-associated polymerase? So what we have here is DNA synthesized by its own virus polymerase. And so if we look at the options, we know that hepatitis B has that. We learned about it in the life cycle. Poliovirus doesn't have DNA. Epstein-Barr virus doesn't have its own virion-associated polymerase, and neither does RSV. Next question. Which of the following hepatitis viruses is an enveloped RNA viruses that has the surface antigen of another virus? Hepatitis D is the unique player in all of these viruses. It is really just a helper virus and requires a hepatitis B active or co-infection. So the answer is A. Questions. Which of the following purified viral surface proteins is the immunogen in a vaccine? We talked about this before. The best vaccine we have is the hepatitis B virus, and you have purified viral surface proteins, and that's what you use. So it's hepatitis B, which is answer A. Next question. Which of the following statements regarding hepatitis B virus is false? A. Hepatitis B e antigen titers correlate with infectivity of the patient. B. The most common worldwide mode of transmission is vertical. C. The window period is when the hepatitis B virus surface antigen is negative, but the surface antibody is positive. Or D. The hepatitis B virus has a reverse transcriptase. Well, we know that A is true, that the E antigen titers correlate with infectivity. We also know that it is the most common worldwide mode of transmission is vertical. C is incorrect. The window period is when you don't have surface antigen, nor do you have surface antibody. The only thing you have is IgM to core. And D, hepatitis B virus does have a reverse transcriptase. Next question. A 21-year-old male received multiple units of blood transfusions following a motor vehicle accident. 8 weeks later, he has nausea, vomiting, jaundice, and loss of appetite. His liver function tests were markedly abnormal. The most likely pathogen is... This is hepatitis C. He has hepatitis from a blood transfusion. We screen for hepatitis B in all of our blood, and we're getting better at screening for hepatitis C, but historically it's going to be the one that's most common. Coxsackie B virus won't usually cause a hepatitis, neither will echovirus. Long-term sequelae of hepatitis C is cirrhosis, hepatocellular cancer, myocarditis, or A and B only. Hepatitis C most likely goes to chronic hepatitis, which gives you cirrhosis, or hepatocellular cancer, so A and B. So the answer is D. Last question. During a visit to Mexico, 4 travelers developed nausea, vomiting, abdominal pain, and jaundice. Further workup revealed the illness to be caused by a small, non-enveloped, single-stranded RNA virus. The serology was positive for specific IgM antibody. The most likely pathogen is Hep A. This is what you get with epidemic hepatitis. It is a positive, non-enveloped, single-stranded RNA virus. It's hepatitis A. Wrapping up Module 35 on viral hepatitis, it's important to remember which viruses can cause chronic disease and which ones are most likely to be acute. Hepatitis A and hepatitis E are most likely to be acute. Hepatitis C even can be acute. You need to be familiar with the ones that most commonly lead to hepatocellular carcinoma, which is C and B. Each virus is different. It has a different genome. It has different serologic markers. They cause disease in similar ways, but you need to be familiar with the different test results at stages in the disease. You can remember lamivudine, which we use to treat some of them. You also need to remember that hepatitis D, or the delta agent, is not a full-fledged virus all by itself. It can either cause superinfection when you've got an established infection of hepatitis B, or co-infection when they both happen at the same time. Serologic markers are going to help you flesh that out. Next, we're going to go to Module 36, where we'll talk about arboviruses.